Good evening, everyone. So good to see you this evening. I'm glad that we could be together. We had a webinar yesterday for our pastors. I see some of you have returned. That's wonderful. The webinar yesterday was really super helpful and very well done. So I'm glad that we can be sharing this time with all of you again tonight. We are very, very fortunate to have Dr. Susan Michaels-Strasser as our presenter. She reminds us that faith leaders, both our lay leaders and our ordained leaders, as you know yourselves, are really important to the ability of a community to hold together, to make it through crises, to trust and lean on one another. And in her work, she draws the implication that's obvious once you hear it, that faith leaders are also important in being a resource for the health of a community, both physically as well, and in so many aspects. And you'll hear more about that tonight. You're also going to hear about, and I'm really thankful for this aspect of the presentation as well, the effects of COVID-19 that are not immediately obvious on our communities, and how our communities of color in particular are more deeply impacted by this virus. And there's some really, I found in the webinar yesterday, some really important information that moved me as a person of faith to think about ways that I could respond more constructively, more graciously, more powerfully. Tonight, Dr. Michaels-Strasser is going to focus particularly on emerging treatments, give some really good information about vaccines and what measures need to be taken to ensure that once a vaccine is effective and available, that access to that vaccine is equitable and fair. In addition, she's going to share some information about how pandemics can be ended, thanks be to God, and making sure that communities can emerge from these experiences healthier, stronger, and more united. The silver lining, right, that is part of our faith that we always look for. At this point, I'm just going to invite Assistant to the Bishop for Communications, Roberto Lara, to share with you some instructions about how we'll conduct the webinar tonight, and then I'll be back with you.
Thank you, Bishop. Hello, everyone, and welcome again to this webinar. Again, my name is Roberto Lara, and I'm the Assistant to the Bishop for Communications and Development. And before we start tonight's presentation, I want to provide some information regarding our digital time together. Please note that everyone has been muted. The goal of this action is to avoid any background sound, and in that way create a more enjoyable experience for everyone. However, if you have any questions.
A living organism, and it is like a parasite. It needs to be in something, an animal or a human being, to survive. We call this virus a novel virus because it is new. Although we have seen viruses like this corona or this crown-like type of virus with this red outcropping, we've seen this, and we know of many others that cause flu-like symptoms. This is a novel virus. That means it's a new virus, with new properties that we have never seen before. It is a zoonotic disease. That means that it has jumped from animals, wild animals, most likely bats, to humans. And there may have been what we call an intermediary host, another animal that it went to, and then to us as human beings. But this does happen periodically. With global warming and climate change, as well as increasing numbers of people living in areas that were previously uninhabited, going more into wild habitats, this will happen as people eat what we call bushmeat or wild animals. The risk is always there. And one microbiologist said it may be once in 100 years that the alchemy is right to infect humans. And when it does, it takes off like wildfire. And this is very true because it is a novel virus for which we, our bodies, do not recognize it and have no power against it. So what is the difference between this SARS-CoV-2 virus and influenza? We've heard in the news some people saying it's just the flu. And for some people, it might feel like just the flu. But for us in mass, as the public, it is not just the flu. And there are many reasons for that. One of the first reasons is we have vaccines and treatment for influenza. We do not have a vaccine, and we have a few emerging treatments that seem to be helpful for SARS-CoV-2, but there is no vaccine and no widely available, well understood treatment for this new virus, this novel virus. Many people have some immunity to seasonal influenza from earlier years of repeated exposure and illness, but none of us has immunity to SARS-CoV-2 unless we have been infected and developed antibodies and recovered. But even then, we are learning that there are people who can become reinfected with SARS-CoV-2 with maybe a slightly modified strain of the coronavirus. And we see some people getting a second infection and actually getting more ill. So we are learning all the time about this, and it definitely is not the flu. We know that the symptoms are similar, these what we call upper respiratory tract infections, infections that affect our nose and our mouth, and eventually, sometimes for some people, their lungs. We do know that the incubation period, or the time from which one is infected to show symptoms, is shorter for influenza. It's about 5 days for the coronavirus. So it can take a few days before someone begins to show symptoms. And that can make it harder to control, because we would have to think back, oh, what was I doing 5 days ago, and where might I have gotten infected? So that can make it a more complicated process to control the pandemic. And I'll talk about breaking that chain of infection in a moment. And having a longer incubation period makes it harder. And that is why in the past, as we learned from HIV, when there is a long incubation period, people could have HIV for years and not know it, and potentially unknowingly pass the virus on to a family member, a loved one, their child. So that is a concern. So looking back, and we're not looking back very far, only early 2020, but I was talking to a colleague today, and we both said it feels like a lifetime ago, because so much has happened in these last few months. So we remember early in the year hearing about the emergence of this novel or new virus in a part of China called Wuhan, where there was an open air market, where there was the selling of animals for food, which is done in many, many places in the world every day, all over the world. But for some reason, a virus was able to jump from an animal to a human being and to infect a human being. And this is what viruses are always trying to do, because as I said, viruses are parasites and they need a living organism within which to survive. Normally they live in animals, but for some reason there was a jump to human beings. On March 11th of this year, the WHO declared this a global health crisis, which was significant in that it is an official act, officially determined, defined act, which allows for opening up funding and resources and marshaling people together to develop a cohesive, all hands on deck response when we know that we collectively are dealing with something. And an epidemic, just for definitions, is when something is happening at a greater rate than it normally is. So in some places, we have viruses and flu viruses all the time, but there can be rapid increases in the numbers around. And that's what we saw with this novel virus, a rapid increase in the numbers of people being infected, not only in one country, but all across the world. And we saw how quickly it spread. And once it goes to every continent in the majority of countries in the world, we call it a pandemic or a widespread epidemic. We remember back to March, which again feels a long time ago, but back in March 17th of this year, there were only, as you can see with the blue arrow, less than about 10,000 cases of COVID-19 in the United States. So just take that in for a moment. Less than 10,000 cases in the United States in March. So between March, April, May, June, July, August, September, now mid-October, more than 200,000 people have died from the infection and more than 7 million people have been infected. That has happened in the span of that short period of time. So we know we are dealing with something that is fundamentally shaking us to our core, the rapidity with which it's spread and how lethal it is. There we go. This is a picture I took, I think, in late June, early July. I remember it was a warm day and I was riding my bike downtown. And this is one of the hospitals downtown. I'm sure many of you recognize it. But what was significant to me about this, first of all, is, it was July, I think early July, and I was getting on my bicycle after having been stuck indoors for a long time, just like all of you, being happy to be out in the sun and being able to move around. I was nervous to go into this little park. I remember it, but I wanted to sit down and have something to drink. And I was nervous to get anywhere near anyone else. So I sat at a table by myself and others were doing the same. But I was really struck very quickly, realizing that this white rectangular shaped truck was not part of the building. It actually is a refrigerated truck that had been brought in to house bodies of people that had perished to COVID-19, and was a stark reminder, a vivid visual reminder of what we are dealing with. And so that was where we were in the summer of this year. In New York, we have been amazing. I must say, people have been amazing to really turn this around, to get it under control from being the epicenter of the COVID-19 virus in the world for many months. And New Yorkers really came together. There was strong leadership, decisive and clear information for people to allow us to protect ourselves and our families. And we don't see this anymore in New York. Unfortunately, that's not the case in many other parts of the United States and the world. So what are the challenges and opportunities here? When there are challenges, there are always opportunities. So this is a novel virus. We know we have no natural immunity and no vaccine. We know that people can be asymptomatic or show no symptoms. And that causes what we call a silent spread, which can make it more difficult to stop and to control. We also know that what in epidemiology we call the R0, or the reproductive number, is greater than 1. What that simply means is that if I am infected with COVID-19, statistically speaking, I'm more than likely to infect 1 or more people. And if I'm able to infect more than 1 people, we then have the potential for exponential growth of infection, of people with infection. Just as we learned in math class, 1 becomes 2, 2 to 4, 4 to 8, 8 to 16, 32, 64, 128, and on and on. And you can see how the numbers grow very quickly. And this is what we saw, lived, and experienced in New York. And this graph is able to visually show that between March 11th, when it was declared a global crisis by WHO, and April, late April, this exponential growth in the number of cases. But as someone in public health, I knew back in January and February that this was brewing, that there was community transmission. And we can talk about that more. I know there were some questions from people around, what do we mean by community transmission? So this was in our community, but suddenly in mid-March and by April, we knew what we were dealing with because it was right in front of us with the numbers of sick and ill people. This is a real challenge on a number of levels, but one of the significant challenges over the last number of years, the last decade, there's been a pullback in funding for public health. And I am a nurse and a clinician, nurse practitioner, but I'm also someone who believes in public health, in thinking broadly about our health system and our preventive healthcare services. And this has been increasingly underfunded in the United States. And unfortunately, I believe it has taken something of this magnitude to get us as a population of people to really see why public health is so critical to our health, our welfare, our economy, and our global health security. Public health really is central, like faith, to everything that we do. Without our health, it is very difficult for us to do much else. And we've seen that very poignantly. The challenge also is complicated because the messaging that has been out there has been terribly confusing and contradictory around COVID-19. And what people need most right now is clear, consistent information. And many of our leaders have not done that. And it has been hard for people to hear and learn and understand through the noise that has been out there in social media and on the nightly news, in the newspapers. And one of the things I want to point out through this table is to show you that although the vast majority of people who are infected with COVID-19 will do well, will do fine, 80% of people will do fine. They may have mild flu-like symptoms or moderate flu-like symptoms, but they will be fine. That's the bulk of us. 80 of us will do fine, but 20 of us will not. 20% of us will not. And when you think about a virus that was able to go all the way around the world in the matter of weeks and a few months, it could infect not thousands of people, not hundreds of thousands of people, but millions of people. And even though, as you see on this table, that the case fatality rate, which means the number of people who die for every case of COVID-19, is lower than SARS, previous SARS, and MERS, which we heard about in the last 2 decades, SARS and MERS, it is far less lethal than SARS or MERS. The absolute number of people being infected is thousands of times greater. So that means, in a nutshell, that many more people will be infected and many more people will die. So when you hear in the news that, well, most people will be fine, most people will do just fine, it's not that big of a deal. That's true for most people, but not everyone. And as people of faith, as Christians, we are called to think of everyone and the least of us. And when we know that 20% of our brothers and sisters can have a really, really hard time with this virus, and of them, a small percentage, but a very large number of people will actually die. And this is why we must sit up straight and say, we are all in this together. This is something that even though maybe I'm young and healthy, I don't have any pre-existing conditions, I'll be fine. It's not that. It's about all of us. And it's about the collective. And what is my role in keeping myself safe so that I can keep my family and my fellow human beings safe. So in public health, we take these challenges and opportunities and we try to prevent infection, detect infection, and when those two measures have not done what we needed to do, we have to rapidly respond and mitigate or reduce the negative impacts of the infection. And this is what all of people in public health and healthcare have been trying to do over the last number of months. As we could see with that earlier graphic, I'm sorry, let me just go back to bring this message home. While we looked at seeing a small number of cases in mid-March, by that point, the train had already left the station and there were many, many people already infected. And that's why we see this wildfire ballooning of cases, because what was really happening in February, late January, February, early March, was widespread community transmission. And it was not detected, or it was detected and not listened to, or the correct measures were not taken. And we can talk a bit more about that at the end of the slides. So our goal is to break the chain of infection, to find the person who is infected. And that person we call a case. And those that come in contact with this person are called contacts, close contacts. And I'll define what a close contact is, because many of you had questions about that, about how do I know if I was exposed or not, or if a parishioner was exposed, or what about if someone in my community has become ill, what do we do? So we know that there has to be someone who is infected, and that is called a case. And for it to continue and to go on and continue to be in our world, that case has to come in contact with other people. So in this diagram, how many contacts does this one person have? So in this diagram, this person has 5 contacts. And that is not uncommon when we live in a family with brothers and sisters or aunts and uncles, or we have to go work and be close to other people. It's not uncommon in our daily lives to have close interactions with 5, 6, 7 people, even more. And so that is why we've had to take radical changes to our behavior and the way we socialize. So who is a contact? And I really should say a close contact. And the way we determine this in public health and in contact tracing for COVID-19 is 2 numbers, 6 and 10. And these are what you need to remember. A close contact is someone that has been in the environment of a person who is ill within 6 feet of them, or 2 meters. So 6 feet of someone who has been ill, with symptoms or not, it doesn't matter. With a mask or not, it doesn't really matter. It's 6 feet for 10 or more minutes. That is how we determine someone who is a close contact. So if I was in a room with someone and they were sitting way across the room, the doors were shut, the windows were shut, but they were 15 feet away from me and we were talking. And neither of us had a mask on. And we talked for 3 minutes and then we left. That person would not be a close contact. But if I was sitting with someone for dinner and they were sitting right next to me, even if we both had masks on, it'd be hard to eat dinner with a mask on, but if we both had masks on, we're chatting for 20 minutes and we were close together, that is a close contact. So it has to be 6 feet or less, so that proximity, for 10 minutes or more. And again, this is not an exact science, but these are the guardrails, the parameters we use to identify those people who if they are deemed a close contact, need to isolate, need to go into quarantine, what we call quarantine. So that is our attempt to break the chain of infection. And so can we break the chain of infection without a vaccine? This is a bit of a rhetorical question, but yes, we can. And New York City showed that. It showed that we could dramatically reduce the numbers of people with the infection. We did not eliminate COVID-19 without a vaccine, but we drastically reduced under 1% the number of people with the infection, which is amazing and is 100% a testament to personal behavior and community-wide behavior. So I want people to understand that there is incredible power that you hold already to fight this infection. And that is social distancing, mask wearing, hand washing. And that is all we did and everything we did in New York to bring the numbers down, to get rid of those refrigerated trucks, to allow our nurses and doctors to get back to taking care of people with heart disease and diabetes and women having babies. That is all and everything we did without a vaccine. And so there is great power in those simple but profoundly impactful steps that we all did. Staying at home, going out only when necessary, keeping our distance, no matter how hard it is, and we want to hug someone, and we want to handshake, and we want to be socially connected, because we are social beings. But those things that we did to modify our lifestyle made the difference. So yes, we can break that chain of infection. Just quickly, what is the difference between isolation and quarantine? It's just a terminology that you may hear. Isolation is for people that are ill with the disease, so we want to isolate them. But it's very similar to quarantine. It's also a type of isolation for people who are deemed close contacts. Again, 6 feet, 10 minutes or more. So what are the global priorities to address COVID-19? We have public health priorities, we have health system priorities, and we have health workforce priorities. And people of faith have an important role to play in each part of this Venn diagram, in each of these aspects of public health. So limiting the spread and saving lives. You can be messengers of what you know can protect ourselves. You can be messengers of the importance of caring for others. You can be messengers of how important it is, how my interactions affect another person. No man is an island. No person lives in this world without affecting others. And we need to realize that and accept that as part of our responsibility as people of faith. Health system priorities, providing quality care for the critically ill, as well as maintaining essential and emergency services, and being able to provide ongoing care so that life can go on. Health workforce priorities, providing safe and effective care in a well-supported and safe environment. And I know many of you have been supportive of the health workers out there, the frontline essential workers driving the buses and the subways and delivering food. All of these people need to be supported as they are playing a critical role in helping all of us to stay safe. So the strategies we have right now are ones we've had for many years: hand washing and mask wearing, surveillance systems, and we're very lucky in New York to have a very strong surveillance system. We can get down to local neighborhoods knowing what is going on. Containment through isolation, contact tracing, and quarantine to slow the spread of the disease. And I'm helping to lead up the contact tracing at Columbia University. And the biggest challenge we have is not the diagnostics, not the testing. We are getting testing back in 24 hours. It's not knowing who has it and who's been in contact. The biggest challenge we have is human behavior. People doing what we know will make a difference, to break the chain of infection. And as faith leaders, you can play an important role in reminding people what their duty is, not only to themselves, but to others, to break the chain of infection. We need to use mitigation strategies, social distancing measures, and communication like tonight. And I'm sure for many of you, you probably had something that would have been more fun to do than sitting here listening to me talk. But you've chosen to be here, and that says a lot that you care for other people and you want to increase your public health literacy. And so thank you for taking the time to do that. You can see in the picture here how a sneeze or a cough or singing an anthem can spread virus. The force of our breath can bring about life, but it also can bring about illness when we spread virus when we are ill. And that is why it's so important for people to stay home if they are not feeling well and to care for themselves and take that time to heal. Today, unknowing to me, is Global Hand Washing Day. Just a reminder to focus on hand washing, reminding people to hand wash. It really makes a difference. We teach it to our children. We remind children as parents and teachers, wash your hands, wash your hands, wash your hands. And there is a reason. It is one of the most important things we can do to safeguard public health. There are germs all around us, on our phones, on our glasses, on our papers, everywhere around us. So washing our hands as much as possible makes a big difference. And we'll talk a little bit more about if the virus can be transferred on things like paper. We'll talk about that more in a moment. This is a hand washing video. How are we doing on time? Do I have time to show just a very quick video? You think that's okay? I'll go ahead and do it. Let me just pull this up. Give me one moment. And you can watch this again on your own time, but I found this to be the best video I've ever seen on hand washing because it shows very clearly what it means to wash your hands. It's not just running your hands under the faucet. So give me one moment. Here we go. And as you can see, this nice video shows how we need to rub every part of our hands.
Doctor, we're still seeing your PowerPoint presentation.
Oh, sorry. One moment, okay? Sorry about that. Here we go. I'll start the video again. You should be able to see it now. I'm just going to move this and I'm going to go back. Okay, here we go. As you can see in this demonstration, they're using white gloves with black paint to show how much it takes to hit all of the parts of our hands, our fingers, in between our fingers and our thumbs, as well as our nails and our wrists to make sure that we have fully washed our hands. And we've all probably seen videos or movies of doctors and nurses going into the surgery and they're washing their hands and coming out like this. And that is a good example of showing what really good hand washing is. And obviously we don't always wash our hands that way, but that is a good reminder for all of us of what proper hand washing really is. Can you see the next slide that says a window of opportunity? Yes, okay, great. This is a slide, I won't go into great detail, but just shows how we must work quickly to break the chain of infection. We have a small window of opportunity from the time someone is infected and has symptoms and has the potential to spread the disease to another person. And we only have a few days to find them and put them into quarantine, or encourage them to stay at home in quarantine so that they can wait and watch if they've become infected. And that is the only way we can break the chain of infection, by identifying those who are sick and identifying those people who've come in contact with them through the definition that you all know now as a close contact, 6 feet, more than 10 minutes. And they need to be identified quickly and go into quarantine and wait out that period of time, those 2 weeks, to see if they too develop COVID-19. And those 2 days are our window of opportunity, because that is the time within which their body is either fighting the virus off or becoming ill with the virus. So we have a very small window of opportunity to act and break the chain of infection. As I said earlier, and very quickly, we know that most people, about 80%, will have mild to moderate symptoms, 15% will have severe disease, and 5% will have critical illness. And if you think about your community, your neighborhood, your street, or your church body, if you have 100 people in your community, 80 of us are going to be fine, but 5 of us will die. And when you put it in those terms, it becomes very clear why it's so important for all of us to be on point and doing what we need to do to break the chain of infection. Where are we today? And I put in the new numbers after yesterday's numbers for the session yesterday. And I must say it was hard to put in those numbers because each one of those numbers that I had to update today is an individual, and they weren't 10 or 100, they were in the thousands. And it was really hard to do that from one day to the next. It was a very visceral, very real understanding of how quickly these numbers go up. So today we have 38 million cases in the world, over 1 million deaths. In the United States, we have almost 8 million cases and 217,721 people who have lost their lives in the United States to COVID-19. And as you can see there, the deaths in the world compared to the deaths in the United States, we have about 1/5 or 20% of the world's deaths, and it did not have to be this way. And we have an important role to play going forward in making sure it doesn't continue. And as you can see from the map, where there is more red, there is more COVID-19. Granted that some of the diagnosis is limited in some countries because of less testing than we have in the United States. But we still do not see the numbers of people dying, coming to the hospital severely ill in other countries. And I work with many countries in Africa, and they are not seeing the levels that we are seeing here. And we would see that people would come to care. I've worked in Ebola, and people do come in for care when they are ill, and it's not happening elsewhere. It is happening in a number of countries, and these are the countries with the highest burden of disease right now: the US, India, Brazil, Russia, and Colombia. So public attitudes, for some reason, and we could talk about this in a moment, why masks, a simple face covering, has taken on so many dimensions of anger, frustration, but also for many people, a source of protection, which it really is. We know that mask use in the United States is very variable. Where there's more purple, there's more mask use. This can be shown throughout, and you see differentiation throughout the United States. We know that the community impacts have been immense. Education has changed, working parents working from home, frontline workers having to go out and face people in the grocery store, the pharmacy, on the bus, in the subway, each and every day. job loss and economic uncertainty. It's been horrific for many, many people to lose their jobs and to have economic uncertainty. We live on Restaurant Row, our church is on Restaurant Row, and I can see the restaurants just working as hard as they can to stay open and to have people come and be able to eat safely. And as the bishop said at the beginning, we have seen the tremendous social determinants of health and racial disparities in the number of people becoming ill, morbidity, and the number of people dying, mortality. So COVID-19 and the social determinants of health, this virus has really shown the stark divides in the United States. 33% of hospitalized COVID patients in the US are Black or African American, yet only 13% of our population is Black or African American. So our African American brothers and sisters have had an unequal risk and a greater burden of the disease. It has had a devastating impact, not only on the number of people becoming ill, but as you can see in the right-hand bar chart, the number of people dying. For example, in Chicago, while only 30% of people living in Chicago are African American, they have been 69% of the people dying from COVID-19. And Jesus teaches us to care for everyone. And there is no scientific reason that this should be happening. It is the social determinants of disease that are causing this tremendous disparity, not only in quality of life or people becoming ill, but in who lives or dies. And there can be nothing more fundamentally unjust and worthy of peoples of faith time and attention than something like this. And I believe COVID has put a mirror to us as Christians to what is wrong in our society and what we can do to change it. So what does the future hold? Vaccine development. We have about 142 vaccines in preclinical trials right now. We have 35 vaccines in small scale safety trials. You've probably heard Dr. Fauci and others talking about the phases, phase 1 safety trials. We have 19 studies of vaccines in expanded safety trials, that's phase 2. We have 11 vaccines in large-scale efficacy or effectiveness trials. And as we all know, we have 0 approved vaccines to date. What we do know, though, is that the world, the scientific community, is in a sprint to get a vaccine to all of us as quickly as possible. And because of science, the world has been able to really rapidly get these 11 vaccines to phase 3. And historically, as you can see with the orange or yellow bars, this is the typical or historic amount of time it would take for a vaccine to go from research to approval. So typically it would go from starting in 2020 and be approved by 2036. So we've heard about more recent types of vaccines, for example, for hepatitis or for chickenpox. These vaccines took years to go from research to approval. And what we are doing, the scientific community is doing right now, is accelerating every phase. And that is not because they're cutting corners, but it's because we are using 2 things. We are using the technology, all of the technology that has been developed to date. There has been infusion of funding to many companies and institutions to help them get into this race to find a vaccine, which is helping accelerating the phases of clinical trials. We have many people willing to come forward and be subjects in the clinical trials. And we have a lot of support at all levels, including ramping up manufacturing of the vials, the needles, and all of the things that are necessary to give out vaccines to the entire world, literally. So there is much happening in a very compressed period of time, but there are no cutting corners. The science community will not allow that to happen, despite any pressures that come their way. We have late-stage vaccine candidates, and I'll go through these very quickly before we open up for questions. One you may hear of is the Moderna vaccine with the National Institutes of Health, where Dr. Anthony Fauci is. It was shown to provide protection in monkeys and has yielded promising results in humans. Phase 3 began in late July. The plan is to enroll 30,000 people across 89 US sites. And if it is shown to be efficacious or effective, Moderna has agreed to produce 100 million doses for the United States and 20 million doses for Canada. You can see the next, which is a Pfizer vaccine. It is launched in May with phase 1 and 2, which yielded promising results. Also in late Germany, entered phase 2 and phase 3 clinical trials. The next is Johnson & Johnson. They're based nearby in New Jersey. They are working with Beth Israel Deaconess Hospital, and they have found in phase 1 and 2 trials that it has yielded promising results, again, in studies with monkeys. They launched phase 3 in September with a goal of enrolling 60,000 people. Unfortunately, on October 12th, I believe, they stopped the study because a person had a serious event at the same time as getting the vaccine or days later. And we can talk about that a little more. So that vaccine trial has been stopped or halted. It has not been stopped forever, but they are waiting and looking at what happened to this person and seeing if it was attributable to the vaccine and if there is something they need to do differently moving forward. Another example is the AstraZeneca vaccine with the University of Oxford. I'm sure you've heard about this in the news. Also showed promising results. They began phase 2 and 3 clinical trials in England and India, and phase 3 clinical trials in South Africa, Brazil, and the United States. Our university and the group I work with, ICAP, is part of the phase 3 clinical trial for AstraZeneca. Unfortunately, there was a woman in England who also had a serious event around the time after she got the COVID-19 vaccine. And so the vaccine trial has been halted in the United States. We actually have a mobile van that is sitting in our parking lot waiting to be allowed to start up again. But it is halted in the United States while the US scientists look at what went wrong. It has started again in Europe and elsewhere. So that study was halted, is halted in the US, but has restarted in other countries in the world. I'll skip this slide, but it's here for your information. What we are looking for in the vaccine to measure, is it a valuable vaccine? Is it meeting the standards that we need to mass produce it and get it out to people? And there's a number of things about the profile of the vaccine, as well as the context within which we will use the vaccine to make that determination. And on the right are those things that we will be looking for, that it has a high level of efficacy, at least greater than 70% efficacy, that it has a good level of immunity. We would obviously hope for something that would have at least 3 years of immunity, but I'm sure if it is less, we would push forward with the use of that. And that it is able to get at this reproductive rate, or this R0, which allows us to reduce the transmission to other people and get to a point where we have enough people vaccinated and not able to transmit the virus to others. The estimated global vaccine need is massive, 5.6 billion people, equating to 11.2 billion doses, assuming that it would be a vaccine that requires an initial shot and then a booster shot. So the numbers of vaccine vials that has to be developed is massive. And you can see here what the manufacturers have announced as their commitments. Most of them have a capacity in the billions and have made commitments to develop and produce for the United States and other countries millions of vaccines if their vaccine is shown to be effective and gets approved. So the US vaccine need for seasonal influenza is about 175 million doses a year. Herd immunity for coronavirus requires approximately 70% of the population being vaccinated. So that herd immunity means that we have enough people vaccinated that it is very unlikely that we would have the emergence of another epidemic. You may see one person being infected here, another person being infected over here, but we wouldn't see this rapid increase if we have 70% of our population having being immunized and protected against COVID-19. That's what we mean by herd immunity. And that translates to 200 million US residents requiring a vaccination. And if you think about going to see a doctor or a nurse to get a vaccine, that's a lot of patient encounters to happen to get us to herd immunity. Assuming a 2-dose regimen, that means 400 million doses, and publicly announced and promised prices have ranged considerably from $4 to $37 per dose. And for people without health care, without financial means, that can be a burden. And also just getting to a hospital or to a facility that has the vaccine, the transport costs, the opportunity costs can be great. We do know that wealthy nations represent just 13% of the world's population, have already acquired more than half of the promised doses of leading COVID vaccine candidates. So already, even before we have a vaccine, we know that there is inequitable distribution going to happen with the COVID-19 vaccine. Ensuring global access obviously is very important to global health security and to getting on with our life as a global community. So an organization was formed by Gavi, the Vaccine Alliance, a coalition for epidemic preparedness innovation called CEPI, and the WHO. It will act as a platform to support research development and manufacturing of a wide range of COVID-19 vaccine candidates and negotiating their pricing, just like we did with HIV, to allow for the scale up and access to life-saving vaccination throughout the world. It offers doses for at least 20% of countries' populations, diverse and actively managed portfolio of vaccines, and an initial aim to have 2 billion doses by the end of 2021. So let's go back, 2 billion doses, but we know that the world will need, the world will need many more than that. It will need hundreds of billions of doses. Next, there is a framework for equitable allocation of the COVID-19 vaccine. There is a proposed framework for the United States allocation of a COVID vaccine. It recognizes the distinctive characteristics of COVID, the groups and individuals that are most susceptible to infection and severe illness, the varying rates of illness and death amongst these groups, and it incorporates lessons learned from prior mass vaccination efforts. So rest assured that even before we have a vaccine, a viable vaccine, there are people looking at the critical importance of ensuring health equity and addressing the racial inequality and discrimination that will be inherent in our society in people's getting access to the vaccination. We have a phased approach that is being planned for the allocation of vaccine. Phase 1 would be a jumpstart phase for high-risk health workers and first responders. Phase 1B would be people of all ages with comorbid and underlying conditions and those that are significantly at higher risk. And then older adults living in congregate or overcrowded settings, as we saw with nursing homes in the US. Phase 2 would include K through 12 teachers and childcare workers, critical workers in high-risk settings, people of all ages with comorbid underlying conditions, putting them at moderate risk, people in homeless shelters, people in prisons, jails, and detention centers, and all older adults not included in phase 1. Phase 3 would be young adults and children, workers in industries and occupations important to the functioning of society, and then phase 4, everyone residing in the United States who did not have prior access. And so this is an attempt to be measured and equitable based on what we know will protect the public at large and society at large. But we do know as well, with the political rhetoric that is happening, the vaccine acceptability, the numbers of people willing to take a vaccine, has decreased dramatically in the United States over the last number of months. And we see that in a recent poll, only 49% of people said they would get vaccinated if a coronavirus vaccine became available. And as the world scientists work night and day, literally, to try to find a vaccine, and people put themselves forward to be subjects to see which vaccine will be the most effective. We have significant challenges from people saying things about a vaccine that may not necessarily be true. What would a successful vaccine look like? It would be protective. It would be durable, meaning that the protection would last. It would clearly show a reduction in illnesses and hospitalizations. It would show reductions in mortality. It would be safe, and by safe we mean that it wouldn't have severe events as consequences or as side effects. People may have pain, they may have mild fever, they may have headache, they may have muscle aches. Those would not stop the safe use of a vaccine. What would stop the use of a vaccine being deemed safe is a significant event, someone who has a significant adverse event. A vaccine will only be acceptable if there's high uptake, if it is available for everyone and works for everyone. And we know that the elderly usually require a higher dose of the vaccine. Some of the clinical trials that are currently happening do not enroll children. I do know of one vaccine trial that is enrolling children as young as 12, but it will take time to have a comfort level to then give the vaccine to infants and very young children. Vaccine manufacturing and distribution is an important consideration. Some of our vaccines require what is a cold chain for them to be kept refrigerated. And in many parts of the world, even in the United States, in Native American lands, a cold chain, refrigerated trucks and refrigeration are not guaranteed. And so that will be a consideration in which vaccines go to mass production. The role of masks, irregardless of a vaccine, will remain very important, probably one of the most important things throughout the rest of this year and most of next year. Masks will be a part of our life. So it's important to know that even when a vaccine comes, there will be a time period in which we need to remember the 6 and 10 rule, wearing vaccines, washing our hands all the time, and really being careful in how we socialize and socially distance. We also know that transport will be a huge challenge. The COVID vaccine will require 8,000 jumbo jets to deliver as many doses as needed throughout the world. So we have our work ahead of us. Once we get the vaccine, it's not going to be done and dusted and all done. We're going to be in this for another year, working through this, and we need to be together and on point to do that. So COVID pandemic continues to grow and evolve with over 35,000 cases worldwide. The global trends indicate that it's growing and accelerating in certain parts of the world and parts of the US. Vaccine development is occurring at a rapid pace, and several challenges will need to be overcome to get us to a safe and effective vaccine, and more importantly, to get us to a point where we have at least 70% of people vaccinated. And the equitable allocation of the vaccine is critical to scientists and to people of faith to address the evident and persistent health disparities observed in the United States and the world. I'll end by saying thank you, stay safe, stay well, and stay connected. And thank you to my colleagues who helped with this presentation. I'll stop the sharing.
Dr. Michaels-Strasser, that was phenomenal. Okay, everybody, don't forget to breathe. That was a lot of information. There is no test, but what you get is an overall picture of what the situation is from an expert in the field. Just a tremendous amount of information. And I just want to say that yesterday, the presentation to the pastors was slightly different. So we've got a new PowerPoint today. That's an amazing, huge amount of work. So thank you so much. We have some time for questions. We're scheduled to end at 8:30. So we do have some time for questions. So Pastor Strasser, you're going to coordinate those. So let me turn it over to you.
Thank you, Bishop. I'm not used to calling my wife doctor, but Susan, why does the vaccine focus on the production of antibodies instead of using weakened antigens? Should I read it again, or you got it?
No, that's okay. There are many types of viruses, and I didn't have time in this presentation to go into the variety of vaccines that are out there. There are many types that use a variety of strategies: live virus, attenuated virus, killed virus. But all of them hope to produce an antibody response, because the antibodies are the immune response that fights the infection. So all of them will take proteins or parts of the virus DNA, which is the antigen, and make a vaccine that will be safe, that produces a robust and durable antibody response.
Thank you. These questions are many, some I'll go quickly. How can one continue to manage wearing a mask and other precautions as positive, at the same time standing for one up, when nowadays when people are standing up for their own rights as a contrary position? How do you respond to that? How does someone continue to support mask wearing when other people are using their own rights as an alternate position?
And this is something that I think has been the biggest sadness for me in the United States, because it didn't have to be this way. We could see wearing a mask as a patriotic act. Put a flag on the mask and wear the mask. And it hasn't been. And to me, this is a simple, powerful tool that we have that people all over the country were willing to make for free and give out for free. In New York, they're on the subways giving them out for free. And it simply is a false choice, a false dichotomy, in my opinion, or my belief, because it's not about me, it's about us. And I cannot be free if everyone around me is sick. And so this is simply not true. I would not go down the street speeding at 100 miles an hour. That is not my freedom. My freedom is to live and to grow and to be part of a society that is healthy. And mask wearing does not inhibit that freedom. It's a false dichotomy, and it represents something much different than that I was looking for my mask, that piece of cloth. And I think this is something we have to remember. It's very hard and complicated here because it's horrific. People have died for asking someone to wear a mask. And I think this is something that you and I need to discern about in the years to come, why there is such anger and knee-jerk response to actually hurt someone else because they've asked you to do something to protect yourself and others. This is a deeply religious question, in my opinion. It goes beyond public health. So I can't tell people to wear a mask because we know that people have been hurt from simply asking that. But we do it through our actions. We do it through the way we carry out our lives, the way we wear a mask. And this is what we can do to be a model of that. And where you can, to speak truth to what is really going on here. It's not about my freedom. It is about my ability to be in society as a safe and caring member of society. And as people of faith, there's nothing more important than that.
All right, next question. Susan, am I at risk if I go to a funeral or a visitation at a funeral home for someone who has died of COVID-19?
Well, you all should know the answer now. If you go, you wear a mask, you go and pay your respects, you stay for less than 10 minutes, and you don't get closer than 6 feet. And you can be there, moving around, but it's that 6 feet that is really important. Don't be in one area with others close to you, 6 feet or less, for more than 10 minutes. That is what's most important. I would feel comfortable to go to a funeral just as I do to go out to dinner if I am coming in for a short period of time and then going to my own space where I have that 6-foot buffer around me. And that can safely be done. And we in New York have shown that because we have opened up and people are moving around with their masks on, and the numbers for many months had not jumped up.
What if the person died of COVID, the person in the casket?
Again, as I said, viruses are parasites and they need somewhere to live. And we do know that they can live in the air for some short period of time, possibly. The science is still out on that. But again, if you are in a space for 10 minutes or less, keeping your 6-foot distance, the chances of getting COVID-19 are very little. A person who has died has been embalmed and there is no virus around that person.
Should children in Sunday school wear masks?
Yes. Children should be encouraged to wear masks and they should be wearing masks. We do know that some children, very few, but a few have died of COVID-19. Children also are more likely to be infected and be what we call asymptomatic without symptoms, and they can unknowingly spread the disease to other people. So although they are little, they can still have a profound impact on either being a part of the chain of infection or breaking the chain of infection. Just as we teach our children to cover their mouth when they cough, we can teach them to, right now is the time we need to wear a mask when we're out and about.
Are we at risk for COVID-19 from receiving mail from church or packages in the mail?
No, we don't believe so. And you may have heard the word fomites in the news. A fomite is just innate object that we hold or touch. And the chances of someone with COVID-19 holding your mail and then you taking it and getting the vaccine is very, very little. It's not zero, but it's exceedingly little, because what would have to happen is they would have to be symptomatic, or not symptomatic, but they would have to be actively infectious, coughing on themselves, putting their hand on this. Then I would have to go exactly where they touched it, immediately touch my face all over the place. So if I'm wearing a mask, if I'm washing my hands, the chances of that actually happening are nil. Don't worry about that.
So you're saying that for us, that the transmission through touch, through objects, is much lower than through the air, the respiratory.
It's almost, I wouldn't even worry about it. It's immaterial. And if you wash your hands and things like that, where the high touch areas are faucets, toilet seats, toilet flushes, those kinds of things. But the mail, no.
Okay, then what about between church and church services? If we have two, how do I clean, and what cleaning do I have to use? Special cleaning products in church?
Soap and water is the best. If you want to spray, you could use Lysol spray, something like that. It works very effectively. You can spray it on and you don't have to wipe it off. Just let it dry on the furniture, on the wooden pews or whatever you use. Just spray and leave it to dry.
And which surfaces do I need to spray in church?
The high touch surfaces, so guardrails, stair rails, buttons on elevators, doorknobs, those kinds of things that we all touch.
Can we get COVID-19 from food?
Faucets.
Can we get COVID-19 from food?
No.
Can animals carry the virus?
Paper, it's similar to the paper.
Can animals carry the virus?
Yes, and that is how it jumped from animals to humans. But that was caused by either excessive handling of an infected wild animal, most likely a wild animal. But I don't think there have been known transmissions like from cats or dogs.
Got it.
I can look a bit more, but no.
All right. Is it okay to promote blood donations within
Yes.
our congregation?
Yes, 100%. Yes, the world needs blood donations, and that is not a risk. The health workers know how to protect themselves and you, and blood is screened, routinely screened for various pathogens or things that could cause illness.
Is it safe for me to go to the doctor to get care for my other medical conditions?
Yes. The doctor's offices are doing a lot to screen their staff, to screen the people that come in. They're often doing telehealth, if doing visits by phone or by video. But if people go in, they follow the same procedures. If you go to the grocery store, everybody's going to have a mask on. They're going to wash their hands and have the encounters be short and sweet and keep that distance.
Are there any air purifiers or these machines that can reduce the virus in the air inside so that, and remove or destroy it in the air mostly or completely? Is this something I should follow up with?
Yes, I mean, if you have the ability, and it's a bit of a luxury to buy these high filtration systems, you can do that, but it's not a be all and end all for coming together. If you can open the windows, just as Florence Nightingale taught us, open the windows, open the doors, put on fans, wear your mask, and keep socially distanced. Those, again, are the tested, true things to protect us. Air filtration is like icing on the cake. If you can have it, wonderful. But there are many countries in the world where that is widely not available, and they have not had the level of COVID-19 that we do.
Last question for Bishop. Bishop, could you talk to us a little about Christmas? Any ideas for Christmas services or ideas you have?
Sure, thanks, Pastor. As you could tell from Dr. Michaels-Strasser's presentation, if we look at August 2021 as a vaccine being widely available, that means that the adjustments that we have made as pastors and lay leaders and congregations will need to stay in place. And I vividly recall when I first encouraged suspending in-person worship that I hoped it would be over by Easter. And here we are now in October, which means we're going to have to be flexible about worshiping at Christmas. Especially for lay leaders, I want to encourage you to be sensitive to the fact that one solution is probably not to decide that on Christmas Eve you'll have 6 different services, because that means time in between to clean thoroughly. But more importantly than that, means the stewardship of your pastors and worship leaders' energy and ability to continue to function. Our pastors are a precious, precious resource. And the suggestion that there might be 6 services on Christmas Eve and 2 on Christmas Day, and is, please don't do that to your pastors. They're wonderful people. Consider all the adjustments that they have made on top of all the adjustments that we have all made, and be good stewards of their energy and their safety and their mental and spiritual health. So there are going to be lots of things that we can do to observe Christmas in different ways. One of the suggestions that came to me that I'll share with you, and before I do that, let me also say that the staff in my office is going to be working on coming up with some ideas. Feel free to share those ideas that you have with us, and then we're going to be sharing them back with you so that you can have a meaningful Christmas. But one of the ideas I had was to think about, if we're having Zoom worship, how about having members of your congregation share pictures of their homes, maybe of their nativity sets, and what makes them special, and what they mean to you, or how you decorate and how you observe Christmas as a family. And that will give inspiration and ideas to one another. And that's something that you probably want to begin thinking about now, but we'll continue to share ideas with you so that Christmas can still be a meaningful religious celebration as Jesus enters once again into our experience, into our human lives. And as we know from that original story, at perhaps one of the most conflicted times in the history of the world, especially for the Jewish people, Jesus came in and brought peace and hope. So we can do that too, because we are followers of this wonderful Savior who brings us peace and hope, even in the most, especially in the most stressful of times. So care for your pastors, care for one another, and continue that amazing creativity that has been such an inspiration to me and my staff over these past months. You have been a formidable blessing to us as you've continued to be and find ways to be church together. So we're grateful for that. So we are at time. Pastor Strasser, thank you for your wonderful job facilitating those questions. Dr. Michaels-Strasser, thank you so much for sharing your, not only your expertise, but your passion and compassion with all of us tonight. It's really been a great experience, and we are indebted to you for that.
My pleasure. It's a privilege. And I really asked Arden, I wanted to do this quite a while ago, because as I saw the social cohesion begin to break down, I realized that faith leaders are central to social cohesion, and faith leaders and faith communities hold us together. And this is a time to step up and play that role, not only with the people in your community, but the wider community as well, through your actions and through your words. It means more than many of you, I think, may realize, that central grounding rock figure role that you play in society. I firmly believe that.
Nice, thank you, thank you. Friends, we have a wealth of information on our website, MNYS.org. There's a whole section devoted to COVID-19 resources for you of all different kinds. So if you have further questions, you can look there. Also appearing there in a couple of days will be answers to other questions that we couldn't get to, as well as the presentations that Dr. Michaels-Strasser made yesterday and today, so that you can refresh your memory or catch something that you might have missed this time through. So please feel free to access that. It's there as a part of our stewardship to care for you. I am going to pray us out tonight and then finish with a blessing and wish you a blessed night. So let us pray. Dear God, among the many words that we heard tonight, these emerged in my consciousness. It's not about me, it's about us. It's about us as your children here in our Synod, throughout our beloved country and throughout the world. It's about us, you and us, Lord God, together facing the challenges that come our way. And when we consider that it's about us, we know that we have more than enough. We have experts and compassionate, faith-filled people like Dr. Michaels-Strasser to guide us with wisdom and information. We have our ability to do the part that we can do, to wear masks, to wash our hands, to keep safe distance, and to ask other people, to invite other people into this effort with us. Lord God, it's always been about us, about your presence among us, about us being church together. We thank you for this time that we have learned ways that we can be your church in transformative ways in our world. Strengthen our resolve, strengthen our faith, strengthen our love and commitment to one another, that we might together overcome this current challenge and be stronger, healthier, and more united as we go forward as your church in this time. For we pray these things in Jesus' name. Amen. And now may the Lord bless you and keep you. The Lord's face shine upon you and be gracious to you. The Lord look upon you with favor and give you peace in the name of the Father and of the Son and of the Holy Spirit. Amen. Thank you all for your participation, and may God bless you. Have a peaceful night.